Hi there. Can you hear me? Thanks, Paul. You've done half the work for me, so that's great. As Paul says, there was a much more inspiring title that was suggested, but I ended up with that fairly plain title. If there's a message I want you to take away, which I'll repeat at the end, it is that depression is reasonably common in Parkinson's disease. And for most people, it's treatable. And there's lots that you and those around you can do to help make things better for yourself if you do experience depression. So what do we mean by depression? Well, for psychiatrists, depression means it's often called clinical depression, although psychiatrists don't really call it that, but it's more than just having a bad day or a couple of bad days or a time when you're feeling stressed about something. It's a condition that can be quite severe and disabling and cause you to have a lot of stress and distress. And when psychiatrists are diagnosing depression, people need to have at least 5 of those possible symptoms there, including low mood, or loss of interest in things, change in weight or appetite, decreased or increased sleep, effects on your energy, slowing of your thinking or movement, feeling tired, thoughts of that you're not a good person or lower self-esteem, and sometimes those thoughts can become increasingly exaggerated to the point of being not in touch with reality. People can also have worries about their physical health and worry that they've got serious illness that they don't have, or become more preoccupied with physical illnesses that they do have. It can affect your ability to concentrate and remember and to make decisions. And for quite a few people who experience depression, they can have thoughts that life's not worth living. And sometimes that can progress to actually having thoughts about wanting to end your life or even acting on that. And you've all seen the public health campaigns that various people have done over the years to increase depression awareness. I think it's great that people have a much greater awareness of depression and an acceptance that depression is something that people can experience, and that there's less of a sense of stigma associated with depression. And that's borne out by the actually surprisingly high rates of antidepressant use in the general population. So I bet there's a few people in this room who are on antidepressants, more than you might think. So depression's quite common in Parkinson's disease. So if you look at clinic samples, people coming along to see their neurologist with Parkinson's disease, about 20% of people will screen positive for depression. In community samples, the rates are about 10%. And at some stage in the course of having Parkinson's disease, around about 40 or 50% of people will experience depression to some degree. So what are the risk factors for developing depression? So part of it is how severe your Parkinson's disease is and how long you've had it. If you've got cognitive problems associated with your Parkinson's disease, and Paul Jones is going to talk about cognition and Parkinson's disease later, so I'm not going to focus on that in great detail. If you're on Parkinson's treatment, if you're female, If you've previously had depression and anxiety, and I've already said it's pretty common, even if you don't have Parkinson's disease, then you're probably at increased risk of developing it with the stress of having Parkinson's disease as well. So people might ask what part of the brain is affected in Parkinson's disease, and the simple answer is the answer's getting more complicated the more we research into the brain. So psychiatrists, our main theory has been with depression that there are changes in what we call neurotransmitters, and lots of you will have heard about dopamine because you've learned about Parkinson's disease, and that's one of the important neurotransmitters that can be involved with Parkinson's disease. So are another couple of neurotransmitters. One's called noradrenaline and one's called serotonin. And you would have heard Paul talking about SSRIs, that's serotonin reuptake inhibitors, one form of antidepressant. There are other ways of looking into what's happening in people's brain and when they have Parkinson's disease and depression, and there are complex imaging studies that look at connections between different parts of the brain, or metabolic activity in different parts of the brain, or what we call brain networks. One of the important networks in the brain is a brain network is a whole different number of parts of the brain all working together and interacting together. One's called the default mode network, and that seems to be possibly more active in people with depression and people with depression and Parkinson's disease. The default mode network is, I hope lots of you are not in the default mode network at the moment. It's when you're not actively paying attention to doing something or focusing on thinking about something outside of yourself, but more sitting quietly in resting mode with internal thoughts. And so that's one thing that we think might be happening. What else could it be if it's not depression? Well, Paul showed you that diagram of the fluctuations of treatment, fluctuations of your movement, and how anxiety can follow that fluctuation. The same thing can happen with your mood when a person goes into the off phase, when their dopamine treatment wears off. And just more general undertreatment of Parkinson's disease can be associated with appearances similar to depression. Adjusting to depression, you heard, I thought the poem that we heard right at the beginning was a real description of what I imagine it's like to experience Parkinson's disease and have to go through the process of adjusting to that and accepting it. People can have less severe forms of depression or depressed moods, but perhaps not severe enough to meet the criteria that I set out at the beginning. Could be anxiety, which Paul's talked to you about, and anxiety and depression commonly go together. So it's pretty rare to see someone who's depressed who's not experiencing anxiety, but it's fairly common to see someone with anxiety who's not particularly depressed. I'm going to talk a bit about apathy in a minute, and then people can have genuine physical health problems and symptoms associated with Parkinson's disease that can cause slowing of movement, lower energy, confusion, hallucination. So it's important to think about, is there something else physical going on that could be this instead of depression? Obviously, people can have more than one of these things going on, or depression plus one of these things going on. So I talked about the fluctuations, but it's important to think about what else can happen when people's dopamine levels are fluctuating. So people can also feel low in mood, but also anxious, experience hallucinations. So apathy. You've probably heard the word apathy. In the clinical setting, it's diminished interest and diminished emotional expression or responsiveness. And it's quite common in Parkinson's disease, and obviously there's a bit of an overlap with the emotional changes in emotional expressiveness that can happen just as very commonly in Parkinson's disease. The commonly used definition is it persists for more than 4 weeks, and it's a change from usual behaviour. And psychiatrists like to think about whether it's having an impact on the person's life. So it's also seen in a range of other neuropsychiatric disorders as well as Parkinson's disease. And it's pretty common at some stage in Parkinson's disease. So really apathy means a difficulty getting yourself up and going and motivated and interested in things. And yes, obviously there's overlapping symptoms with Parkinson's disease. I've talked about the affect, the slowed movement, slowing up of your thinking or speech, and a change in the musical elements of speech. That's what we mean by prosody. So pitch, tone, intonation. Sometimes people with apathy can have increase in somatic concern as well, and they can have autonomic disturbances. Symptoms more unique to depression, so if you're experiencing these things, then it's more than just apathy, it's more likely to be depression. So included in that, the worry and what we call rumination. So rumination is like worry on steroids. It's worry that just won't go away, that just keeps coming back, that you can dispel, but it comes back into your mind again and again. Agitation means anxiety and the sense of physical restlessness that goes with it. Feeling guilty and blaming yourself for things is a really common part of depression. It's not typical for apathy. And feeling pessimistic and hopeless, and thoughts of death or suicidal ideation. So those things, if they're coming up, then you and the people around you really need to think, could this be depression? Depression tends to come on a bit more quickly than apathy as well. Apathy tends to be something that evolves gradually over time. Depression can do that, but if it comes on suddenly, that's also a pointer towards depression. So what should you do if you think you're depressed, or you think the person you care for with Parkinson's is depressed? One of the most important things is to talk about it, not pretend it's not happening, or tell yourself you can just buck up or get over it, or that it'll pass. It's important to listen to those around you who might be pointing it out to you as well. And support from family and friends is really important, and will make a big difference in getting through it. It's important to remind yourself how common depression is, and how it can probably, partly because of the brain changes, as I mentioned, in Parkinson's disease, is not your fault. depression can make you feel like it's your fault. It can cause you to have thoughts like you should be doing better, including coping with depression. And it's really important to let your doctor or physician or nurse specialist or other health professional know what's going on, because they all know about depression these days as well, and they know that there are things we can do. So this is taken from a study which is referenced at the bottom of the slide, and the point of that is there are lots of things we can do. On that side of the slide, there's a big list of medications that can make a difference, and on the other side of the slide, there are other things we can do, and I'm going to talk through some of those things, a little bit about medication and then about non-medication things. So getting the Parkinson's medicine as good as you can is a really good first step. If you've got a good going depression, it's probably not going to be the only medication you'll need, but thinking about whether your Parkinson's is adequately controlled is important. And then we have a list, quite a long list of antidepressant medicines that we can try. So antidepressant medicines in general work on one or more of those three nerve chemicals I talked about before: serotonin, noradrenaline, and dopamine. Not many of them work on all of those, but some do. So going back to optimising Parkinson's medicine, there's some evidence that just adjusting the Parkinson's treatment can help. And Paul mentioned selegiline before. Rasagiline, I understand, is not available in New Zealand. But they are forms of Parkinson's treatment that can also affect people's mood by stopping the breakdown of dopamine. This is a study. These graphs are what we call graphs from a meta-analysis, and that's when you cluster together the results of a number of different studies. And that's quite useful in the study of medication treatments in Parkinson's disease, because the studies tend to be quite small. And so if you have a small number of people in a study, it's harder to get a statistically and clinically significant result shown. So this technique means that we can put the results of a number of studies together. It has some limitations around the validity and what you can genuinely conclude, and looking at an individual study often gives you extra information. But anything that's fully one side of the line, not crossing over the line, means that the treatment is effective. And the little diamond that you see halfway down is the sign, that's the summary of the effects of the various studies. So what you can see there is that some monoamine oxidase inhibitors can be effective. The SSRIs, which Paul was mentioning before, can be effective. And the tricyclic antidepressants, which are older antidepressants, but some of you might have heard of them, things like amitriptyline and nortriptyline, also can be effective in treating Parkinson's disease. The SSRIs have been, since that study, studied by quite a few different studies, and you'll see there's various different types. Psychiatrists quite like SSRIs because they tend to have few side effects. In theory, they can make Parkinson's movement symptoms worse, but I haven't really seen that in my clinical practice, and so I think they're a reasonable and good first choice. But there are other things we can try as well. There's another one called venlafaxine, which we quite often used, and that works on both noradrenaline and serotonin. And there's one called bupropion, which works on noradrenaline and dopamine. So theoretically, bupropion could help with both mood and movement. There aren't very many controlled trials of bupropion. There's one small comparison trial that compares it to an SSRI, which suggests it might be a little bit better. One of the things we worry about with bupropion is that anything that increases your dopamine transition, including Parkinson's medicines, can contribute to what we call psychotic symptoms. That's like seeing things that aren't really there, or getting ideas that aren't based in reality. The studies that are available suggest that that's not a common problem with bupropion, despite it theoretically being an issue. This is a little diagram that talks about, it comes from a review article, and that looked at both anxiety and depression non-medication treatments. And you can see that what Paul was saying is there's far less evidence for effective treatment for anxiety. Doesn't mean that treatments aren't effective, it just means that research isn't there. But the darker lines that you see indicate that there's quite a few non-medication things that can be helpful for depression, and I'm going to talk about some of those. So, exercise is good. Breathing and relaxation can be helpful. What they call mind-body activities, such as yoga, can be really helpful. So that's activities that are working on your awareness of your body while you're doing an activity, which is a big part of yoga. And combining that mindful element to yoga. And then talk therapies, including cognitive behaviour therapy, which Paul was talking about before. So cognitive behaviour therapy includes things like activity scheduling. Paul was mentioning activity scheduling as a way of finding out what activities help with your mood. But when people are depressed, activity scheduling can also be really helpful in just helping the person get unstuck from lying on the couch and ruminating. So if you schedule something to do every hour, it keeps your mind, it gives an opportunity for your mind to switch out of that worry and rumination cycle. And then cognitive behaviour therapy, the cognitive part of that is often looking at the negative thoughts that you're having and seeing how realistic and balanced they are. And in depression, people tend to dismiss evidence that disconfirms their worries. So you can see there's a diamond there, well to one side of the line for cognitive behaviour therapy, and it's actually as effective as antidepressant treatments, or more effective than some of those studies. So that is something that can be really helpful. Music therapy is something that's being studied quite a bit in Parkinson's disease, and what they're showing is that it can help both with the movement and the mood. And there's some interesting studies that suggest that music therapy, where there is movement attuned to music, might make people have different connections in different parts of their brain, including using the cerebellum rather than the basal ganglia to coordinate movement. So it can also almost reprogram how your brain is functioning in terms of your movement. There's 4 studies on light therapy which show some benefit. So light therapy, as it's done in experimental studies, involves a person sitting in front of a light box with 10,000 lumens, that's really bright, and for about an hour in the morning. But just getting up in the morning and exposing yourself to morning sunlight is probably really helpful. And that's a really good thing to do for your mood. There's this relatively new treatment called transcranial magnetic stimulation, or TMS, which you may have heard of. And there are a couple of studies, a few studies now of TMS in people with Parkinson's disease, and evidence of benefit. And there's a treatment called ECT, or electroconvulsive therapy. So you might have heard of ECT in the past, and most people's response to ECT when it's mentioned is, oh, do they still do that? It's associated with misuses in the past, and has a lot of concern and stigma attached to it. The way that it's given these days is very safe, and it's actually probably one of the most effective treatments we have for depression. And it can also be helpful in the short term for people's movement with Parkinson's disease. So it's not a first-line treatment, but it's one that we can sometimes use, usually for people who haven't responded to medications, and it can make quite a big difference for people if they really need it. So in summary, depression is pretty common. If you think you might be depressed, think about whether this could be under treatment of your Parkinson's symptoms or apathy. Tell your family and friends about what's going on. Seek help and advice. Share with them what's going on. Counselling and psychological therapies can help, and so can medication, and there are some other treatments as well. There are some things that you can do without outside help that will make a difference as well. So that's all I've got to say. Thanks.